Evening, everyone, and welcome. I am Lauren Gueits. I'm your host of this evening's Airway Health Solutions Masterclass with our special guest, Dr. Mike DeLuke, and we are so excited to have everyone here. Tonight's topic is the fundamentals of diagnosis, the key to orthodontic health, with Dr. Mike DeLuke. So welcome, Dr. DeLuke. We're thrilled to have you, and what great timing. It's National Orthodontic Health Month, so look at that, right? It's like
Yes, yeah.
serendipity here.
Yep. And dental hygiene, right? Dental
Yes,
hygiene
I know. I wanted
awareness
to
month
add
as
that
well.
too.
Yeah.
So our
Yep.
worlds are
So
blending together, and
yeah,
we want to save the world, right?
that's right.
We're trying
We're
one patient
trying.
at a
We're
time,
trying.
and
That's
one
right.
doctor at a time, and one clinician at a time. So I would just like to give you a formal bio because some people aren't aware of your professional background, and then we can
Mhm.
dive into a little bit of your personal journey, and then we can really get ready for a wonderful presentation tonight. So
Sounds
without
great.
further ado, Dr. Michael K. DeLuke obtained the Certificate of Proficiency in Orthodontics and Master of Dental Science degree from the University of Connecticut and is a diplomat of the American Board of Orthodontics. He served as the orthodontist on the prestigious cleft craniofacial team at Albany Medical Center and as a clinical professor at the University of Connecticut Health Center in the Department of Orthodontics. He is presently an adjunct professor at the NSU College of Dental Medicine in the Department of Orthodontics. Dr. DeLuke owned and operated DeLuke Orthodontics in upstate New York from 2005 to 2023 and launched DeLuke Orthodontic Coaching in 2022 with the mission of helping his colleagues succeed both personally and professionally. He has lectured at numerous regional and national meetings over the past 20 years and published articles in multiple orthodontic journals. He is also the creator and host of the Doc podcast, which I'm a huge fan of. And Dr. DeLuke now resides in Naples, Florida, with his wife and two daughters. So welcome. I'm really excited to have you here and for everyone to get to know you a little bit better. But I also like to get to know the audience a little bit better. We have actually 520 registered for this evening. So
Great.
as I say, as long as you guys keep showing up, we'll keep showing up. It's a great validation for the airway health movement. But let's get to know the audience by taking a poll of your profession. I always like to see who's with us tonight. So we'll go ahead and launch that. Couple minutes.
Mhm.
Let's see, 53 participated, 62. And welcome, people are slowly coming in as well. Okay, so let's see, we have 75%. Let's see if we can get up to 90 and see who's here with us tonight. Almost. Come on, guys. All right, I'll go with 83. That's a good number. So let's see what we got here. So here we are. We have a nice mix for sure. I know, these dental hygienists, I love you. You guys are so passionate. You're here like every time we have a webinar or a conversation series, and we have more orthodontists than usual. So, it's exciting. We're going to kick this off. So I actually had the recent pleasure of being a guest on your podcast, the Doc podcast, and I felt like we could have just spoke for hours. We have
Agreed.
so much
Yep.
shared passion, and even though I'm a hygienist and you're an orthodontist, we had very similar experiences as far as our experience in patient care, and really just how we're both so passionate about the betterment of health for our patients and actually for professionals as well. So I kind of want to turn the tables here a little bit. And I know you're very interested in people's journeys, and you do such a wonderful job at personalizing everybody and really getting to the heart of what made them who they are today. And how do we do that without going through your journey? So I would like to give you, the floor a little bit. And I'm curious, as you know, from our last podcast, on your journey. Like, how did you decide that you wanted to become an orthodontist? And then how did you come to the point where now you really want to focus on coaching others in not only orthodonture, but airway health, wellness, spirituality, if you will, just being a good human. So why don't you tell us a little bit of the background story? We'd love to hear it.
Yeah, well, thank you. And thank you for coming on the show. It was great. It's received a ton of great feedback on the episode and for sharing so openly, because I know that's not easy to do. So my journey, from upstate New York, and I wanted to be an orthodontist from a young age. I come from a family of dentists and then orthodontists, but all the way back, I was third generation in the dental profession. And I really wanted to be an orthodontist from a young age. It was one of those that it's like middle school. It's like, I want to do this. And so I made that my goal, ended up going through the schooling years and came out and did become an orthodontist and decided to start my own practice right out of my residency. Did my residency at UConn in the early 2000s and started my own practice within a week of leaving my residency. Literally hung a shingle,
wow.
just started it. And so had to learn a lot about business and management and finance. Started it with some educational debt and not really any assets. And my wife and I put together a plan of how we were going to try to succeed in the practice and financially. And so built the practice up and grew it into what became a very, very big practice, and always knew I wanted to teach more. It was always my passion. I taught throughout my career. So from the very beginning, I was driving back to UConn a couple times a month and teaching the residents at the ortho program. I was running, at that point, just helping with, but eventually took over running the orthodontic part of a GPR, general practice residency. I also became the orthodontist on a cleft craniofacial team up in that area. And so I love the educational side, but I was so busy with my practice, I just couldn't devote much energy, the energy I wanted to it. So one of my goals was in the second half of my career, I wanted to spend more time teaching. And so to do that, I needed an associate. And so I started looking for an associate probably about 13, 14 years into practice. And it just, a few years went by and I just couldn't find anybody that really fit what my vision was. Cause I wasn't looking for someone just to come in and be a set of hands. I wanted someone to come in and share the vision I had and grow the practice and be able to let me scale back and go teach more. And then I would train this person to be kind of in my place over sort of 5 to 7 years. So I did hire one person in 2019 in the summer. And within 3 weeks, I had to let him go. And it just wasn't the right fit. I think anyone out there who runs a business or is part of a business knows it's nothing personal against this individual. It just wasn't the right fit. We thought we had vetted one another. We thought it was going to be great. It just didn't work. And so I learned a lot of lessons in running a practice and a business for that many years. And one of them is when you know someone's not a fit for your team and your culture, you need to just part ways at that point before you go down the road too far. So that was tough. And so I'm so busy. Chris Benson, who is the leader in practice valuations and orthodontics in the country, his team with Benson Koppel, he came to the practice. He's like, you're doing the work of like 2.5 to 3 orthos yourself. How are you doing this? And I said to him, that's why I need help. I need help. And so COVID hit and I had the time to reflect and think a little bit, sleep a little bit, which I wasn't doing a good enough job of, and talked to my wife and just really thought a little bit about what the next half of my career was going to look like. And really felt that if I had tried for this 3.5 years to find somebody, found somebody, didn't work. I got offers to sell my practice to corporate for a lot of money. And I turned it down. I have no problem with people who sell to corporate, but I knew if I couldn't find someone for my practice, they probably wouldn't be able to. And ortho's different. When you take these patients on, they're committed to you for 1 to 2.5 years potentially. And it's, they sign up to be there with you and the reputation I'd built. And I didn't want to do that. It just was not for me. So I had to figure out the plan B, and that was going to be, I guess at this point, maybe plan D. And that was, I decided and made the decision in the fall of 2020, September, right after Labor Day, and made the announcement I was going to phase the practice down that I built. And I literally phased the practice down. So it was tough. It's not easy to do. I made the decision, the community I was in when I started I was the 11th orthodontist in the county. And when I made this decision, there was one left. It's just not an area people are going to practice, and none of them had found someone to come in. So just kind of what happens up there. So I accepted that and decided I was going to make this decision. That being said, I had a lot of patients in my care and a lot of people. We were booked out like 5 months on new patient exams, and multiple months on starts after those exams. So I made the decision we were going to stop all exams, and I would honor any patients that were scheduled to start treatment with me as of that time, which took me to the later part of 2020. So we did. I didn't take any more exams. I literally stopped taking people. And I always say, if you want to know if you're doing good orthodontics, finish every case you started yourself.
Wow. Yeah, yourself.
So it's thankfully I took a lot of pride in my work and the quality of work I did. So it was very doable. And then I had to start telling my team, right? I mean, I told my team from the beginning this was going to happen. I was upfront with them, but they needed other jobs. As I was cutting back, each month I had fewer patients. Obviously, I'm phasing. It's the exact converse of when you build one up, which I'd done almost 2 decades prior, where you're adding people constantly. Now I'm telling people, look, I'll give you 8 weeks notice. I told everybody, I won't let, even if you can't find a job, I'll pay for you for 8 weeks ahead of when I'm not going to need you anymore. And I honored that. And we helped either place people or they found other positions and phased it down. So I went out like I went in, doing everything again, right? All of the background, the lab work, and I mean, I had digital everything. And so it was a challenge. And then in the middle of that, in 2021, my family decided to move to Florida, to Naples. So I ended up for a year and a half flying back and forth and spending time in Florida and then splitting time up in New York and at the practice. And then it worked out well that a guy who's a colleague wanted to buy my building. It was all custom finished. So we bought the building. We had a handshake deal that he would just let me come back as long as I wanted to finish up any of my cases. And I honored that. And I finished every single patient I started by the end of 2022. And the last couple months I was flying up just to see one person. It was a surgery case that got delayed because of COVID, because New York was crazy with not letting elective procedures go on. And so I mean, but I kept my word. I did it. And I never, Lauren, I never regretted it. The whole time I was doing it, I would see patients and interact with them. And there was a lot of sadness, and that was hard. What we're going to talk about tonight, I did things differently than a lot of my colleagues, and patients had come to know and trust me in that. And it was hard to tell them I wasn't going to be there anymore to do it. I would just tell them that at some point, everybody has their day, right? I know mine sooner. I'm in my mid-40s, or now my late 40s, but I was in my mid-40s at the time, about 46 years old. And I said, I know mine sooner than most. That being said, I put a lot out there during my time in practice, and I didn't sort of leave anything on the field, so to speak. And they respected it, because I told them I was doing this so I could go teach a greater population, that I could do more with my mouth and my platform than my own two hands could do in the patients mouths of the patients I was treating. And so I started building up Doc, the new platform, while I was kind of, at first it was just all in trying to survive, to get through this and face the practice down and move to Florida. But once I started, like 2023, I really was able to dig in and start building my Doc content and really start to grow it. And then I launched the podcast in mid-summer of 2023, which my wife always laughs because it was having trouble figuring out how to get my message out there. And she's like, you should podcast. I don't know how to podcast. So that kind of started that. And then it just has gone from there. And now the platform's getting really big. And I coach a lot of docs around the world, and teach now at Nova on the southeastern side across the state from me in Fort Lauderdale. And I love doing that, teach orthodontic residents there. And it's been a cool journey.
Well, you had blind faith, and you just followed your gut and your intuition, and magically things unfold for you. And it's great to never look back. And it's a lot of perseverance that you have. So you have that entrepreneurial spirit as well.
Yeah,
that's
for sure.
And it's not for sissies, right? It's like certainly not.
No. And when you build something to where I built the practice, to face it down and walk away, and we thankfully had made some really wise financial decisions, which on part of my platform I do. My accountant's been on, my financial advisor. I do a lot of talk on my platform about the finance side as well, because we set ourselves up to where, one of the first calls we made was call the financial advisor, like, hey, can we do this? But was really important. And as you were saying before about my purpose, one of my purposes is to help people be more fiscally responsible, especially early in their practice careers, to save and invest better and more wisely. I actually have someone coming on my show about this. Mark McClellan's coming on in a couple of weeks. We're going to talk about that. So it put me in the position to be able to take those calculated risks. So I did it knowing that I was going to be fine no matter what. And one of the really neat parts about it now, Lauren, is I can just do my own thing. I have the freedom to say what I want, teach what I want, do what I want. Obviously at Nova, I respect, the higher ups there.
Right. Of course.
I'm on their turf, and it's their place. I'm just there to help them, but they're great. They give me freedom to teach the residents my approach and philosophy. It's very freeing to be able to just develop the content I want to develop and teach the people that I want to teach.
Well, it's admirable, and we're really thankful that you did that, because you're going to teach so many. Just the guests that you've had on your podcast, I've learned so much and really appreciated knowing people's journeys as well, especially as an entrepreneur. But as a clinician and an entrepreneur, we're all entrepreneurs, basically. If you have your own practice, you're an entrepreneur. So I know we're trying to think about topics for tonight, and you're so passionate about so many, but we decided on this one. You want to kind of give an overview of what we're going to talk about and why, and then I'll just give some housekeeping items after that.
Yeah, we decided to focus on the orthodontic health side and the diagnosis treatment planning side. I am going to show some treatment because to be honest, I think it can get a little boring if I'm just talking about the diagnosis only. So I do mix in some treatment to show how those outcomes can differ based on whether or not you're treated with a certain type of approach, which we'll talk about, versus another type of approach. And that's one thing that I want is a big part of my purpose and the message I want to get out there. We are not taught a lot of this in an orthodontic residency. And I'm going to contrast that tonight, the kind of the standard approach, and then the approach that I learned through my years in practice and through what I picked up by just, as you and I talked about, and in the spirit of Orthodontic Health Month and Dental Hygiene Awareness Month, being able to look at our patient, not just look at their teeth. And so often, and we are just so highly trained as orthodontists, especially, but even general practitioners and hygienists, we're trained to look at teeth. We're trained to look at occlusion. We just study that. That's it. And in orthodontists, it can become very myopic because we sit there and we think it's all about straightening teeth. And I'm going to show you some cases tonight that show you some patients that have some really nice straight teeth, but we didn't do a service for that patient.
Right. Well, we can't wait to see, but let me just do a little bit of housekeeping items.
Yeah.
So the views presented are the opinions of our speaker and are not necessarily affiliated with Lauren Gueits and Associates and Airway Health Solutions. And the following webinar is provided for educational and informational purposes only and does not constitute providing medical advice or professional services. The information provided should not be used for diagnosing or treating a health problem or disease, and those seeking personal medical advice should always consult with a licensed physician or dentist. Always seek the advice of your doctor or other qualified health providers regarding a medical or dental condition. And then also, just to receive your CE certificate, we're happy to provide 2 free CEs for this evening. You must be in attendance for the entire program, and the Zoom software tracks the attendance, so we do not need a code or survey at the end. But now let's get to the good stuff. I'm so excited. It's a thrill and a pleasure to have you here. I can't wait to see this presentation, and thank you for sharing your story. I'm really, really impressed by your fortitude and really appreciative of your gifts to give to others. So let's get to it.
Thank you very much, and appreciate the invite. It's an honor and a pleasure to be here with you all. I'm thinking we'll probably be, it's 4 cases. We're going to go through probably about an hour, I'm thinking, and then we have some time for question and answer after that.
We have plenty of time for Q&A. So that's why I allowed for 2 hours here, because there's a lot of questions when it comes to healthy orthodontics. So
yeah, no, and I welcome the questions too. I actually really am excited about that part. It's always nice when we have time to ask them. So you want me to do a screen share here?
Yeah, please. Thank you.
Okay. I have to go into from the beginning. Good. You've seen it okay?
That's great.
And I'm going to try to go presenter view. Are you still seeing the main frame, or did it switch to presenter view?
We're seeing full screen.
Great. All right, let's do it.
Here we go.
So as we let off, we're going to get into the fundamentals of orthodontic diagnosis and the key to orthodontic health. And that really is the big difference here that we're going to address. Is we're going to focus more on the concept of health than just on straightening teeth and making bites line up. As we said, October is National Orthodontic Health Month and National Dental Hygiene Month. So it is appropriate. And then Lauren and I, it was not an accident. We did work on this as we were chatting a few months ago and said, how can we make this work most effectively? As she mentioned, she was just on my podcast. And at the end of the talk tonight, I'll put that QR code back up and people can scan it. It'll link you up to my content as well as the podcast in there. And I do put weekly episodes out. So try to keep fresh content and fresh guests coming and have some great guests coming up as well. So the big thing we're going to talk about is a two-centered approach versus a patient-centered approach. And when we talk about that, what we want to say is, what is the difference between a two-centered approach and a patient-centered approach to orthodontic treatment? So when we take those two different approaches to orthodontic treatment, what is that difference and what does that look like? Well, there's two sides, right? So we have two-centered and patient-centered. And the two-centered, the decisions are based solely on trying to get the teeth to fit together. In the patient-centered approach, that focuses on the teeth and the health and well-being of the patient. And I'll repeat that. That patient-centered approach focuses on the teeth and the health and well-being of the patient. And that might sound like an oversimplification. It might sound like kind of basically, yeah, Mike, okay, I get it, right? One focuses on the teeth, one focuses on the patient. Well, we're going to go through some examples of how this is a simple concept, but in delivery can be very, very difficult and oftentimes missed. So we're going to go with patient one first, and you can tell by the theme, patient in the background, the removal of the teeth, why this patient was not treated with the right approach. Now, as I said, this patient was actually presented to me at 11 years, 4 months for the first time. This is literally within the first 5 months of me opening my doors of my practice about 20 years ago. And she had been seeing another orthodontist in the community, and they were doing kind of that watchful waiting that we hear about a lot about. And it's not to say the orthodontist is doing anything other than really what they were taught or what we were taught. And we're going to contrast that and talk about some of what that orthodontist was doing in watching and waiting when they came in. So if we look at her images here, the typical problem list, the typical side of orthodontics that we're taught to look for is malocclusion, right? Slight class 2, division 1. She's really not that class 2. Her 8 millimeters of overjet is largely attributable to her retrocline mandibular incisors, which was due to her history of a thumb habit, which had recently been stopped. She has a shallow overbite. She has mild maxillary crowding, severe mandibular crowding with impacted number 22, and an over-retained lower left C, lower left primary canine. Insufficient incisor display with smiling, flat smile arc, lip incompetence, tapered arch form, vertical grower, and no posterior crossbite. So this is kind of the standard problem list you'll see orthodontists or anyone who's treating a case orthodontically look at. And notice the no posterior crossbite. That's a big one. And we're going to come back to that a few times because that is one of the reasons I chose the cases I chose. Now, some of the records on the 2 cases that were treated with a 2-centered approach aren't necessarily the best, but this one was from right in practice. The other one's from my residency. In a good way, I didn't treat patients this way much, if at all, in my practice. And you'll see the difference and why that is. So I had to kind of dig to get a couple cases to show the contrast of how things can go wrong. So, and when it go wrong, I mean by when we treat the symptom or treat the teeth, okay, as opposed to treating the patient, which we talked about. So in that 2-center plan, and kind of hold on, this is what we're going to do. We're going to do serial extraction. We're going to take out the D's now and that over-retained primary cuspid, and then the 4s eventually. And then we're going to use braces to align the teeth, close the space, and deepen the overbite. Now, again, this is how I was trained. This is how a lot of orthodontists are trained. And a lot of it is just, we just don't get to see younger kids. I talk about that a lot on my platform. It's just the way the system is set up. I'm working on that. Laura and I were saying maybe on the podcast episode, we need to join forces and use her skills and entrepreneurship and get her to kind of help out with this, because the orthodontic residencies, you just don't get to treat younger kids. You really don't, unless they have a posterior crossbite or an anterior crossbite, you really don't treat them. So when you see these kids with no posterior crossbite and all these other issues, a lot of those kids are on state funding in an orthodontic residency, and the state won't cover you to treat them. They'll cover you to take teeth out. So that's a big part of the problem. And we won't dive too deep down that hole tonight, but I just want to put that out there, that it's not that these orthodontists are out there necessarily saying that they don't see any value in treating these kids younger. A lot of it is they're just trained not to, and it's hard to undo your training. So what does it look like when we just treat the teeth? Well, here you go. Okay, so we had a treatment plan, right? We had our diagnosis. We understood what we were doing, and by all measures, you could look at this and say, "Oh, decent result." 39 months of treatment time. That is one common factor. Once I started changing my approach, if the patient either did or didn't have a phase 1, but really their comprehensive phase or their phase 2 should be 12 to 20 months in the majority of cases, maybe 24 in a really, really tough case with some impactions. But when you're going 39 months, that's almost a telltale sign there was some misdiagnosis there. And if we look at what things look like, you can kind of look at the mandibular arch and say, it's not too bad, Mike. It's not, we've seen a lot more caved in arches than that on an extraction case. And I'll show you that shortly. And overall, did we accomplish our objectives, right? If we look at the teeth, we could maybe say, well, teeth look pretty decent overall. But what did we do for this patient? And did we do any harm? Did we do the best we could for her, right? We gave her nice straight teeth, but let's take a little deeper dive into it. Well, for one, I had no idea to look at airway. So this is a pre on the left and a post on the right. And when we look at this, we can see just in the 2D, and this is long before 3D was even commonplace in dental practices. That's narrow. That nasopharyngeal area is certainly narrow, and I would bet there's some adenoid enlargement. And we can see even after treatment, it's still pretty narrow. Maybe we could make the argument down in the oropharyngeal area a little better. I did broaden those arches a little bit with the wires and make a little more space for the tongue, so we could say that maybe helped her out. But we didn't do as well as we could have done, right? Because we had no idea anything about her breathing, about her airway. We had no idea anything about her sleep. We had nothing. Her performance in school, her behavioral issues, nothing. So we took a patient from here, and 3 to 3.5 years later, she's here. And I hope you're already seeing some of the things, which I'm not going to give it away, that we missed in this patient and where we went wrong. And we look here, and you can see that tongue kind of squirting through there, right? Just on smile. Now, some patients habitually do that. I understand that. But a lot of times it's more common when there's not a lot of space for that tongue. And then we kind of look at what happened aesthetically to her. So this is where we started with her profile. And that's what we did to her. I don't feel good about that. And this is her at 14 going on 15 years old. I mean, where is she going to be? Where is she today? Almost, 20 years later. And what does that look like going forward? As we know, the nose and the chin will continue to grow, the lip support will continue to fade away, and the lips will drop. And we end up having a greater concavity to that lower third. And so we took a patient who had, we basically just took a patient who we didn't take the time to diagnose the patient correctly, and we treated the teeth, and we ended up with a result that wasn't ideal. Now let's contrast that with patient 2. Little different approach. So this patient presented to my practice later in my career. She was almost 8 years old with a chief complaint. She has shark teeth, evidenced by the rows down there, which the parents, as we know, call them shark teeth. So we can see she's got a lot of things going on. Let's kind of dive into her problem list. So if we just looked at it from a typical standpoint, right? Not looking at it from the patient-centered approach, but typical approach, the two-centered approach, we would say she's class 1. She has moderate upper and lower crowding. She has a retained lower left primary lateral. She has V-shaped arches, retroclined upper incisors. She has a vertical grower, and she has no posterior crossbite. But again, we acknowledge, and we would acknowledge, remember, this would be a traditional approach, that she has V-shaped arches. We do talk about arch form. It's something with the residents. It's a normal standard part of their treatment planning process. But again, here comes that no posterior crossbite, right? So in the orthodontic arena, we are still taught, and I would be willing to bet probably, I don't know this number, but I'm going to guess 9 out of 10. So 90% of orthodontic residents out there are taught. If I'm wrong on that, and people, I'd love to be wrong on that. So if I am and you're learning it differently, please reach out to me. But we're taught that if a patient has a posterior crossbite, if a patient does not have a posterior crossbite, you do not expand them. And I have a really simple example I like to give of this. So let's look at this patient. Here's a totally different patient, similar age, right? Comes in. Look at her occlusion. Well, let's take a closer look. So let's play a little game here. Which patient has a more severe malocclusion? The first patient I showed you, patient A, or the second patient I showed you, patient B. Now, in the orthodontic arena, we are told that patient B does, because patient B has a bilateral posterior crossbite, which is something we don't argue that we need to go in and treat young. But my contention is patient A actually has a more severe malocclusion, because patient A has a transverse deficiency in both arches. See, patient B has a really beautiful mandibular arch form. It's broad. There's no issues there in the transverse. Patient A, by contrast, has a mandibular arch that has caved in and collapsed. So if we just go by the standard tooth-centered plan, right? Not going to, but again, I'm trying to draw that contrast so people can understand. And part of the reason I'm doing this is I really feel there's a big misconception between why orthodontists treat a lot of the cases the way they do. I just want to try to shed some light on our thought process and how we're trained. So we would extract CHMNR now, right? We'd get those primary teeth out, and we would then monitor growth and development. we would try to maintain arch length. Okay. Many of you out there have either do this procedure, this is how you would treat it, or you've seen, if you're non-orthodontist, you've seen your ortho colleagues do this. And then we would most likely take her down a serial extraction pattern because we're trying to maintain arch length. And if you think this isn't something we do, at the upcoming winter meeting of the AAO, there's actually a lecture coming in January. There's a lecture on effective serial extraction. I mean, it is still being taught and something that they really feel in cases like this that should be done. So you take the D's out, and then the fours. So you go get the primary teeth, and you get the D's and the fours, and then braces as an adolescent, try to clean it up. And I think she'd look a lot like that first patient we showed, right? That is not how we want to approach these cases. So I want to contrast that with what it would look like if we took a patient-centered approach to this patient's treatment. And to do that, we need to look at more than her teeth. Let's look at her face. Tired eyes, venous pooling or allergic shiners, Denny Morgan lines, which are those folds and wrinkles they get. I told parents all the time, 7-year-olds aren't supposed to have big bags under their eyes and wrinkles, right? With the parents running around after the 7-year-olds, understood, but the kids are not supposed to present with such tired eyes and such signs of fatigue. Sometimes they'll have that allergic crease on the nose. It's for pushing up on the nose to if they're runny or stuffy kids. Chapped lips, and then something that I kind of coined the term chapped gums. It's not the most technically appropriate, but parents get it and patients get it. Rather than talking to them about inflammation in their gingiva, I love to kind of simplify terms for my patients and their parents and say, hey, look, you got chapped lips. Everybody knows what those are. Well, you got chapped gums too. And a lot of these signs that she had were totally ignored. And then we start to look intraorally, and we notice this thick hyperplastic tissue. Sometimes even some altered passive eruption will occur on these incisors because they just can't get through that tissue. Many of you already know why, and that is the mouth breathing, right? She's breathing through her mouth. It desiccates this tissue. Look how dry it is. And it gets thick and hyperplastic. And a lot of times the incisors can't erupt through it. Then we've got this adherent plaque. You ever have those patients who come in? I'm sure the hygienists out there hear it all the time, where they say, Mom, Johnny, we could do a little better job brushing on those front teeth. And mom's like, I'm in there all the time with him. Every night I make him let me brush his teeth. And I just can't get it off. The only time it comes off is when we come in for a cleaning. That's a telltale sign this patient is mouth breathing through their mouth, whether it be snoring or just at rest during the day. But that's another classic sign of it. Rolled in lower molars. So look at the difference in that versus that other patient I showed. In your mind, take those molars, upright them so that you don't have a steep curve of Wilson anymore. And this patient has a posterior crossbite bilaterally. It's not a hard concept. It's not even really debatable in that sense. I mean, clearly, if you just made the statement, if I upright these molars so their axial inclination is correct and you have a flatter curve of Wilson, will this patient have a posterior crossbite? Pretty much guaranteed yes. And most people are going to tell you that. So why don't we acknowledge that this patient has a significantly narrow maxilla at this point? And the other part is insufficient space for the tongue. And you'll see that all the time in these patients. We can also gather some additional information, whether it be a pediatric sleep questionnaire to start to find out more about this patient's history, or even if you're not comfortable with these questionnaires yet, and you just want to ask questions, right? Just start asking questions. I think a lot of people sometimes are intimidated by adding another questionnaire to their setup. So in the beginning, if you need to, just have this conversation with mom and or dad at the first visit, but you've got to take the time to do it. And that's one big thing. You have to take the time to do it, because we come to find out that this patient has some very severe airway problems. And another big problem that happens in the orthodontic profession is we rush through that consultation process and that diagnosis and consultation process to get back to the clinic. And I've been there in a very, very busy office. It is not easy. We wear earpieces and they're in my ear and it's hard. That being said, you owe it to your patients to take the time to look at them for more than their teeth and try to figure out what is going on a bigger scale. I also lecture on pediatric sleep disordered breathing. I'm giving a lecture at the Winds of Change meeting in January on why should we care about pediatric sleep disordered breathing. There's a lot of reasons to care. It goes beyond the scope of today, but it's really important that we do this. So let's take a little look here and go on a little tour. Let's see if we can play it. Let's see if it goes through. There's some videos on how I had to take an airway tour because I get a lot of questions on that. So hopefully it'll go through for everybody. Yep. So what I essentially do is I just go in, and I'm doing this with a cursor, just like I'm holding now here. I do this in the room with the parents, and I just say, hey, we're going to go on a tour, and anywhere you can see black, there's air, and anywhere you can see gray or white, air can't go. And they get it. They understand it. This particular patient where I am right now was a little tricky because she must have been, she swallowed. She was a fidgety one, and sometimes they will move during the scan. So she swallowed a little bit, and that's why I think we see that soft palate and uvula raised up there. So it obscures that, obstructs that posterior airway a little bit, but we can still get a nice feel for what's going on. And some of you have a keen eye, and you might have noticed what we saw up in that nasopharyngeal area, as well as in the nasal passageways. And then I'll just go through the mouth. And that's where the beauty of a 3D image, you can think of this versus that, just that 2D Ceph. And we can take the time to go through and actually look through and see those transverse relationships and look at that high vaulted palate and the nasal passageways with not a lot of room, and the asymmetrical maxillary sinuses, and that tongue with that invagination in the dorsum, that sort of inverted V in the inverted heart shape. You see it there, the heart and that V in the dorsum of the tongue. So when we start to see all this, it's painting a picture in our minds of what's happening with this patient. I now know that she snores, that she's mouth breathing. I see the clinical signs and symptoms of this. Again, I'm not diagnosing her with obstructive sleep apnea. I'm not saying I'm treating her airway. I want to be very clear about that. Orthodontists get really kind of weirded out about this. And like, we're not treating airway. We're not able to do that. Agreed, we're not. That's the job of the physician. That being said, it is well within my scope to look at anything from sort of the highway up on this patient. And I had an attorney on my show about a year ago who's an orthodontist and an attorney. And we're kind of going back and forth on whether you need a cone beam or not. And this is a low dose. All my cone beams I took on these kids were low dose, less radiation than a 2D pan for this full 3D image. And we were having back and forth about that and having that discussion. And he clearly said, no, you're right. It is your place for anything from sort of the neck up is within our scope. So take the time, educate yourself on how to look at these images. Don't be afraid of them. We know the anatomy, especially my orthodontic colleagues out there. I mean, heck, we go through another round of head and neck anatomy in our residencies. So we know this anatomy. It's nothing new or different. We just have to get more comfortable with them. Sadly, in a lot of orthodontic residencies, they're not taking cone beams. If at all, only by request. They're not a standard practice in the majority of residencies. So the residents, again, just like with the phase one, they come out not really knowing how to learn these. So it's something I've spent a lot of time trying to teach my residents at Nova how to see these images. And I put a lot of content out there online about it as well to help people. So now we recognize some additional factors, right? We recognize that she's got this narrow maxilla. She has a high vaulted palate. She has narrow mandibular arch with a steep curve of Wilson. She has insufficient tongue space, enlarged adenoids. Actually, go back to that image. Let me just show everybody that one. So if you look, you're going to see when this gets up right about to here, I want you to look right in, it's going to come in a second. I'll get my cursor out of there. We're going to see them pop up right, and they're hiding on the 2D, especially with her soft palate raised right there. There they are. You see those adenoids? So we know she has adenoid overgrowth now. There's no way we could see that in 2D, and we didn't know that. We would have missed it. And if we're not looking for it, there's no way we would be able to see it without 3D as well. She also has the venous pooling in the shiners, as we talked about. She has tired eyes, compromised airway. We now know that because she's mouth breathing and snoring, pediatric sleep disorder breathing. Again, not saying she has obstructive sleep apnea. I'm not worried about that. I know she can't breathe. I don't need a sleep study right now to prove to me that this child can't breathe properly. Okay. Sending her for a sleep study at this point, to me, is overkill. Not everybody lives in an area where there is a sleep center. Not all sleep centers are standardized in how they look at these. Not all are looking at RERAs and body movements. Some are literally just looking at the AHI. So it's really important, and they're expensive. Not everybody can afford these. Not everybody has insurance for these. So it's sort of convenient, especially for academia, to say, well, if they don't get a sleep study and I don't know what their starting AHI is, then I don't find that there's a need to treat them. I'm not saying that people have to listen to me on this. I'm just saying I strongly disagree with that statement. It was very rare for me to refer a patient for a sleep study. Not never, but it was very rare. And because I know all I need to know about this patient's airway right now. Okay, so does it help me if she has an AHI of 2? What if she comes back with an AHI of 0? Because you see that a lot too, because with kiddos, they have a very much more active sympathetic nervous system. So instead of having events of 10 or greater seconds of obstruction of breathing, of an apnea or hypopnea, they will move or squirm or flip upside down. And so they don't end up having those episodes. So we have to be, and if you could take a kid one night, actually the episode coming out this week with David McIntosh, he's an ENT from Australia. We talk about that. And he talks about the inaccuracy of these sleep studies. So it's really important, that we just understand what we're talking about here and not hide behind a sleep study because we're scared to kind of make our own clinical determinations on these patients. Chapped gums, as I said, she has adherent plaque. We know from the sleep questionnaire, she has some behavioral issues and she's struggling with school and her attention. So think of the difference now in how we approach the care of this patient versus how we approached the care of this patient. And the list of the things we failed to recognize, now I don't have actually most of these because talking with the parents, I actually know about her school performance as well. So she had the narrow maxilla, she had the high vaulted palate, she had the narrow mandibular arch with a steep curve of Wilson, she had insufficient tongue space, enlarged adenoids. We can see them up here, right? We talked about that. I don't know exactly how enlarged, but I can see there's definitely something there. The venous pooling with the tired eyes, compromised airway, excessive C-spine curvature. There's some great articles in the medical literature, one from 2010, one from 2015, that talk about the fact that an excessive curvature of the C-spine is oftentimes related to patients who have airway problems. A big misconception is, oh, well, you put them in the machine wrong, right? They had their head tipped. Well, she's clearly at a pretty neutral head position. And this is something I talk about a lot because it is a big misconception. A lot of times these patients are habitually that way because when your clinicians are trained, at least mine were, that they want to get Frankfurt horizontal as parallel to the floor as they can when they take these images. It's not like your assistants, many of them are going to let your patients have their head like tipped way up. Most of those patients are still looking straight ahead, especially if you use a fixed point on the wall across from them to look at. It's that neck is different. And I saw in so many cases where the neck started with excessive curvature of the C-spine. It corrected. And when they take the final image, it wasn't there, especially in these phase 1 patients where you're dealing with airway issues. And it happens so many times, again, empirical, anecdotal at this point from my standpoint, but it is in the literature. And it shows that the earlier you correct it, the faster it will resolve. If anyone wants those references too, I'd be happy to get them for you. So, mouth breathing and snoring, we know now that she does that. The chapped lips, the parents had told me that she was a mouth breather, didn't pay attention to it. It was on my initial medical history about it, but I didn't know much about it. I didn't really pay attention to it. I'm ashamed to say, but I came out not really knowing that. She has the adherent plaque, she has a tongue thrust, she has behavioral issues, and having poor school performance. So it's sad when I look back for this patient. And, honestly, I feel that's a big part of the reason why my orthodontic colleagues sometimes struggle to acknowledge the need to change in this profession, because it's humbling. Thankfully, I didn't have a ton of patients I treated this way, but I did have some, and I'm not proud of it. It can be really tough if you've treated patients with this traditional approach for many, many years and you have to reverse everything. Then add into it having to build all new systems, train your staff differently, spend more time in your diagnostic and treatment planning room. All of those things aren't super easy to do when you're seeing 75 to 100 patients a day in a very busy orthodontic practice. I hate to say it, it's just kind of easier to keep doing it the way you're doing it and keep straightening teeth. And I'm not even passing judgment on that. I just try to call balls and strikes on this stuff. If you listen to my show, you'll know I talk a lot about this, and this is how I am. As I said in the beginning to Lauren, I don't have to kind of walk the line. I can be open and honest and share my opinion. And I believe that's a big part of it. I'm not giving my orthodontic colleagues a pass. I've been there, and I know it was not easy for me to change. And I made this change when I didn't have a ton of patients because I was earlier in my practice years. So what does it look like if we're going to take a patient-centered plan to the second patient? Well, I'm not going to spend a ton of time on the technique for this because it's not the point of this, but I want to show you some different ways to do it that I developed about 5-6 years into practice. I was doing it with expanders initially. Ironically, again, like I said, this patient, they didn't want expanders. And I remember the conversation vividly. They were like, we're not putting expanders in. And that tied into the behavioral issues that I didn't really come to, but it turned out she was having behavioral issues, speech issues. They didn't want big bulky expanders in her mouth. Had I known then what I know now, I wouldn't have needed to use expanders to do this. And we'll show you that now. So we're going to expand and develop the arches. We're going to remodel the palate. We're going to redirect growth away from vertical. We're going to improve her tongue space. We're going to improve her airway patency and the associated comorbidities. And we're going to create space for the permanent teeth. Notice that's last, right? Because ultimately, in my mind, this is really to help this patient's overall health and well-being and craniofacial growth and development, not to give her straight teeth. Now, that being said, I do have to say, the psychosocial impact, I know some people who talk about this are like, I don't worry if the teeth aren't straight after phase one. Again, I disagree on that. I'm an orthodontist. Maybe that's the reason why I straighten teeth for a living. But that being said, I saw tremendous psychosocial improvements in my patients when you do give them that smile. And if you have, there's testimonials on my website of parents talking about how that changed their child to look so much better. You know, you wouldn't think at 7, 8, 9 years old that would be so valuable. But then you stop and think about how many kids are tortured and teased at young ages for their teeth. SpongeBob, right? Snaggletooth, all these things kids get told. And you start hearing patients tell you, hey, look, like Dr. Mike, she never told me that she was ashamed of her teeth. She never told me she was getting bullied. But once she got her teeth started to get straightened, she all of a sudden liked going to school again. She wasn't crying every morning. So these things are real. So I just encourage everybody. I'm big too. It's not about the teeth at this age. That being said, you can do a lot for a little kiddo. And anybody who's got kids, that my kids are older now, but when they're that age, kids are tough. Kids are tough. So just don't undersell that point to give kids a nice smile. So here she is. This is actually her first adjustment, just 8 weeks into treatment. You already start to see arch development, right? We had just an 014 eye tie-in. I put a 1622 eye tie-in this visit. The tongue does a lot of this. Anybody who's taken my course on this, I love it. They send me cases and examples of their cases, and it's so much fun to watch people do this and change these kiddos' lives. But you can see the chapped lips are starting to get a little bit better. The tissue health, look at how much healthier that tissue is getting. This is 8 weeks. This is the first visit. I put everything in, see him 8 weeks later. The bite ramps disocclusion is a huge, huge key to this. So now we see her 8 weeks later. Now we're 4 months in, second visit, right? Look at the arch development we're starting to get on this girl. So you can see this was during COVID, which up in the Northeast, they went on a little longer. So a lot of my patient pictures from the last couple of years of practice had masks. If we, at this point, you know, again, not getting into the technique, but just to show you, and this is 8 months into treatment, and we're just really shaping those arches, letting the tongue do its work for us. And then in 12 months of treatment time, here she is. It's 4 adjustments and a progress bonding to bond her laterals. That's it. No impressions. This was, you know, before earlier on, a lot of now people are using digital, so it's less relevant with impressions, but you know, you're not fitting bands, you're not expanders, and her airway, her mouth breathing, you're going to hear it from mom. I hope Lauren and I might have to change a little something on the settings, but I hope you'll be able to hear mom's testimonial on this. If not, I can email it to everybody afterwards. Mom gives me permission. It's on my website as well. So if we look at this, I mean, look at where she started on the left and look at where she finished a year later. Who thinks in a year, if we did nothing or was watchful waiting, that this child would look like this a year later, right? I mean, I treated, again, a lot of patients, and that just isn't going to happen. Her whole face is different. I mean, you look at this child and what we did for her by helping her breathe, look at the way as I said, the altered passive eruption, those chapped gums. This is a different kid. Now, she has some allergic shiners still. I did refer her to the allergist going back to the beginning. Mom did not want to take her. I do find that, and maybe it was my approach, but some patients, just especially with kids that were a little tougher and sensory, as you'll hear mom say in the video, this patient was, they're just hesitant. They're really scared that they're going to get, you know, the pricks or the needles or the sticks for the allergies. So they tend to avoid the allergist. But some go, but I wish she had gone, because I do feel there's some atopy there as well. If we look at the side by sides, I mean, look at the shape. And one of the things I love, I find when I used expanders, I would take these arches that were kind of narrow V's like hers, and I would end up with like wide V's, really, really wide across the first molars, but not wide enough where I really needed it. I think everybody out there's treated a case where they put them in expanders only to have those canines still not have room, right, to descend on the top especially. And that's why a lot of orthodontists say phase 1 doesn't work. They're not treating the mandibular arch at all, right? So they're just trying to get a little expansion with an expander of the upper. What can you get? Maybe 4 millimeters, maybe 5 if they don't have a posterior crossbite, trying to cheat a little more arch perimeter. And it tends to relapse back to the lower, and you tend not to have success. This is totally different because you're addressing both arches. I apologize for the angle of the after picture, but it just shows you the difference in the shape of this patient's arches and the space that we have. She did not have large teeth. Look at the literature. I mean, classic study by McNamara in the early 80s. It looked at 104 patients, looked at their dental casts, 54 with severe crowding, 50 with none. He concluded that they essentially had the same size teeth, that it was jaw size that was different. And he actually encouraged the orthodontic profession, James McNamara, who's still going and a strong leader in our field. He encouraged us to focus more on developing and growing arches than extracting and removing tooth mass. So this isn't new. It's just a different way to apply it. Legends like Tom Pitts have been doing this for years and years and years. He was on my show a while back. And so it's been done. It's just not become commonplace. So I'm trying to change that. If we wonder the orthopedic, the beautiful part of the cone beam is here she is on the left, here she is on the right. We just measured this across her primary Ds, got about 6-ish, 5.5 millimeters there. But look at the change in shape. So one of the things I hear all the time from orthodontists, non-orthodontists is, hey, Mike, there's no way you can grow bone. You don't get an orthopedic change of the maxilla without an expander. That's false. It's all about the age you do it. So if this patient is 14, then you're probably right? But the great article by Bert Melson in 1975 in the AJO talked about the stages of sutural maturation from a histologic standpoint. And she took coronal slices and she looked at the infantile, the juvenile, and the adolescent. And the infantile goes up to age 10. And in that infantile range, I mean, it's like an open highway, straight, right? There's nothing there. And you don't need excessive force. Ricketts has done numerous studies on this in the 70s and 80s, showing that light force, 221 to 400 grams of force is sufficient. Braces and wires can deliver that. Easy. 1622, 7025 NiTi wires, they get up 500-600 grams, no problem. So you're just basically doing slow expansion. You don't need rapid. In fact, Profit in his contemporary orthodontics textbook said that performing rapid expansion on patients under the age of 10 is dangerous and can cause facial deformation. So we should not be rapidly, not that you can't use an RPE, you just need to make sure if you're doing it, you need to turn it very slowly, once every 5 to 7 days. You shouldn't be turning these daily or seriously twice a day in these younger faces. You don't need it. Okay, so the canines, I love this. I mean, like almost a centimeter. And that's the beauty of it, right? I don't care these teeth tip. They're the primary teeth. But man, does it decrease your incidence of canine impaction, because these canines, they just, as this patient grows, they just start to follow. And they follow that track. And you almost never see impacted canines. Really, unless it's just an ectopic tooth or a malformed tooth that just sits up there horizontal that almost never going to turn. Other than that, I mean, it's so rare. But it's because we did that, right? We reshaped and rebuilt the arch form. You look at the pre and post pans. Again, think of the difference in this patient and that first patient. Think of the difference in this patient's quality of life, because we just didn't focus on her teeth. Beautiful room for the teeth. We look here, and as I said, it's a little tough. So what this is the pre, and we put our crosshair up here right at that spot. I went back and paused on the video, and you can see that adenoid tissue there. And so 12 months later, it's gone. Now, again, a little bit deceiving, because remember, the soft palate and the uvula have descended. So they would be almost, more straight across here. But that doesn't change the size of those adenoids. And as Audrey Yoon's article in 2022 in Sleep said, they talked about the fact that just expanding alone oftentimes decreases adenoid size. And beyond today's scope to go into that in depth, but it is real. And I see it all the time in these patients. Because we take a patient-centered approach, post-treatment, I looked at those nasal passageways again, knew mom hadn't taken to the allergist, recommended she did, because there's definitely some turbinate hypertrophy there. I do feel that she is still having an issue, but because she's not mouth breathing or snoring, even harder sell now. Mom really doesn't see much of a need to go. And I get that. I mean, her kid's doing well by all measures that she can tell, and she is a little bit sensory. So I'm going to try to play this. Hopefully, Lauren, can you let me know if you don't hear the volume? And Mom, we were talking about her breathing. Hearing it. And if you want to tell me a little bit about how she was breathing before treatment.
Prior to it, she was a mouth breather. I would hear her snoring at night. Sometimes I would go in her room and try and listen to hear if she was having true apnea. Mm-hmm. And I heard it a little bit, but mostly it was just snoring and mm-hmm. kind of like noisy breathing. She was pretty restless. I was a sleeper. She'd be all over the bed. And then when you asked me how it was going, I honestly forgot that that's what she was doing, because she sleeps soundly now and doesn't get up in the middle of the night and has become a very quiet sleeper. So
that's awesome. Yeah. And that's, you also said, you were mentioning about the challenge that you probably would have faced with an expander, turning it at night, and with you working later, that might have been a hard thing to do too.
yeah, so I work till midnight 3 nights a week, and I know that she tends to have some more sensory issues than, some other kids, and would have had a challenge with us doing anything in her mouth. So it probably would have been at least a 2-person job. And being that I'm not home 3 nights a week, I figured it would be, done twice a week, and then probably not even done the other 3 nights, because it just wouldn't have been possible. And I can only imagine the tears and drama that would have incurred every night trying to do it. So it was great to not have to.
And would you say this was pretty much set it and forget it, like once we built the system?
Oh, it was amazing. It was amazing. She had mild discomfort for the first 2 days, and then one other time during the entire treatment, again, she had, I think, like a day and a half where she took Motrin twice, but then was like, no, I'm fine. Ate everything, was fine, like didn't even have to be concerned about it the entire experience. It was really great.
That's awesome. Well, that's why we do it. And like we said, that picture of the eyes, that tells the whole story, is the difference. And I love that. That's kind of the thing I've noticed, that you can't really quantify, but you just look at the patient's eyes before and after when they were breathing not the right way, and then you do this and you get them breathing right. It's just night and day for them. So cool. Well, thank you for sharing that. You did great. I'm proud of you for getting through everything. Cool. So you can see it's an amazing experience for the patient, and this is what she was a year later. It's stable. They grow into it. They look great. It's easy if they need second phase down the road. I have a bunch of other courses I put out in content and publish articles in Ortho Town showing patients that don't need a second phase. But again, for tonight's purpose, it's really just to talk about the contrast in styles between a two-centered approach in that first patient and a patient health-centered approach in this one. And so going back to our initial slide, what is the difference, right? So we're going to finish these two cases by just showing you a little bit of that difference side by side. Here were the two girls initially. That was patient 1, pre and post. That is patient 2, pre and post. These are the two patients. I don't know many people who would choose the profile on the left over the profile on the right. I don't know many people who would argue that we weren't a part of both of these, right? That we weren't a part of helping cave this patient in and a part of helping this patient more full in the lower third. Looking at the smiles, there's no question. And the eyes, this patient's eyes are getting darker with time. She's still not sleeping right. I guarantee it. And with time and age, that's only going to get worse. But we missed it. We missed it because we didn't take the time to focus on more than just her teeth. Patient 3. So now we have 2 more patients. We're going to contrast again. Similar type cases just to kind of show you another little example of this. This patient was in my residency. So this is going back over 20 years ago. And she was 13 and a half with chief implanted buck teeth. And we look at her, and the typical approach that we would take to this case is looking at her and saying, okay, typical problem list. She's got class 2 division 1, retrognathic mandible, 10 millimeters of overjet, deep impinging overbite, protrusive maxillary incisors, retrusive mandibular incisors, moderate upper crowding, severe mandibular crowding, tapered V-shaped arches, lip incompetent, no posterior crossbite. Again, we highlight that because that means we really don't need expansion, right? Because she doesn't have a posterior crossbite. Think of the difference of this patient if we got her young, right? If we got her when she was 7, 6, some in this group especially would go even earlier. But just think if we, at the very least, for the orthodontic community, just think of the fact if we got this patient in that 6, 7 year age range, it'd be a very different story what this patient would even look like. And then there's some things we're going to show we could have done differently even at this point with the patient 4 that we did with this patient. She also has a very strong chin, strong pogonion, and that a lot of times intimidates my orthodontic colleagues from wanting to help grow the mandible. But I find it actually softens it when you help bring that mandible forward in treating a lot of these cases over the years. So we took a 2-centered plan. We extracted 4 bis on this patient. Upper 4s and lower 5s, we call it in ortho world. Upper first bis, lower second bis. Because she's class 2, we're trying to set up our anchorage. We then use braces, wires, elastics to level, align, and close spaces. So I did treat this case from start to finish in my residency. It is my work. All the pictures and everything I'm showing you is all mine. But But I failed to recognize that this patient had a narrow maxilla, had a high vaulted palate, that she had a narrow mandibular arch and a steep curve of Wilson, insufficient tongue space, enlarged adenoids. You can see them up here on that image. I'd love a 3D, but I guarantee there's some hypertrophy there. She had the venous pooling and shiners, the tired eyes, a compromised airway because she's mouth breathing and snoring. I guarantee it. I don't know that, but by all the other signs, I'd be willing to guarantee she is. We did not even ask those questions in our new patient inventory at the time. And chapped lips, chapped gums. And I mean, it's just hard for her to even touch her lips together. So I don't know how when this patient is at rest at night, she doesn't have her mouth wide open. And she did have actually poor school performance. That was an issue with her. So, and socially, she struggled mightily. I remember this patient very well. She had some real social issues as well. And you wonder how much of that was because of her airway, her breathing, and her appearance, right? That we left her like this for that long. So we went in and we treated the symptom, the teeth. And when we did that, we look at her and boy, you know, I don't even like looking at these pictures, but they are what they are. And it's a common result that a lot of you probably see out there. And 30 months of treatment time. And if you first look at it, a lot of people look at this and say, that's a great case. Like, what are you worried about? That's a really well-treated case. Because if you have a tooth-centered mentality, you could maybe make that argument. Say, geez, you have nice straight teeth. I mean, way better than what she had. But let's look at this, really. I mean, let's drill down into it. I mean, this was her maxillary shape before. This is after. Now, again, it's tough to size these exactly, but I'm not too far off on the size of these teeth. We totally retracted everything to try to bring those upper teeth back. I mean, we had to. What else were we going to do, right? Maintain some good torque control as best I could, but still, it's not something to be proud of. And here's a real humbling one. You ready? Look at that mandibular arch. I mean, the restorative dentists out there are probably squirming in their chairs because they know this patient's going to be in their chair down the road for TMD issues and bruxism and everything else. So again, it's a misdiagnosis, right? We're taught you can't expand the canine width in these patients. We're taught that you have to extract on these patients or you'll tip those teeth out of the labial bone. It's not the case, but it is still what is being taught out there. The reason it looks different is that she had her 7s in the picture more here than here. So that's why you see a little difference in the positioning. Here's her smile. Okay, we'd improved, right? We're not going to disagree with that. I mean, she doesn't have a horribly unesthetic smile. Not like that first patient that we just had such insufficient incisor display. So it's not like she has a horribly insufficient smile, but you know, look at those tired eyes still. It's like they're more tired, right? I mean, this poor girl, looking at it now, I'm convinced she's not breathing. Look what we did to her profile. I mean, it's not okay. It's not okay to just take this and look at it. But this is what happens when you're just looking at their teeth and not more. This is what you get. So let's go to our last patient and just start to draw some contrast here when we look at our whole patient and the whole patient's health. And this patient came in to see me right before I got a cone beam. I got a cone beam in 2014. So she was a little before that. And so we didn't have a 3D at that point. So I wasn't even really I was just starting to kind of figure airway out at that point. It was just starting to be on my radar a little bit more. I was just starting to use the braces and wires instead of the expanders. I was, when I was early on, when I was expanding these kids with expanders young, 20 years ago, when my practice, I was really doing it just because I didn't feel right about pulling teeth on patients whose jaws were narrow when the teeth weren't too big. That's really why I did it. I really had no clue about airway or any of that. And a lot of parents along the way would say to me, Dr. Mike, do you think the fact that he's breathing better has anything to do with these expanders and so forth? And honestly, I'm kind of embarrassed to say it, but I was just like, well, maybe. And there's some studies out there that say that it can help breathing, but I just never connected the dots. And it wasn't until many years in that I really started to become more aware of this, but it's hard to change those habits. So when we look at this patient, let's talk a little bit about her chief complaint was overbite. They call overbite. I know we all know they typically mean overjet, but so when we look at her, the typical problem list, all right, not the patient-centered, but just the standard orthodontic problem list is going to be her malocclusion, right? The way her teeth fit, class 2 division 1. She does have a subdivision. She's more severe on the left for sure. Those can be kind of tricky. She has 9 millimeters of overjet, deep impinging overbite, mild maxillary severe mandibular crowding. She has an impacted lower right canine, number 27. Her chin point is off to her left. She has a retrognathic mandible, steep mandibular plane angle, signs of some vertical growth there. Retrusive mandibular incisors, most likely from the lip pressure. tapered maxillary arch, excuse me, and lip incompetent with mentalis strain. And then again, our favorite, right? No posterior crossbite. So with that amount of crowding, which is significant, and knowing what I told you before, that we're not taught, you really can't expand too much at this age. You can't help grow and develop the bone. You can't tip those teeth forward too far. You want that incisor-mandibular plane angle at 90 to 95 degrees. You're going to tip them forward too far if you try to treat this case non-extraction. I think we can see that most people would look at this case, and if you're just trying to treat her teeth, you'd extract 4 bis, probably again, the upper first and the lower second. You do braces and wires and elastics to try to level line and close spaces, just like we did in patient 3. But that's not what we did here. And so let's go into what a patient-centered plan would look like. Because now we recognize narrow upper and lower arch, high vaulted palate, insufficient tongue space, venous pooling and shiners, tired eyes, compromised airway, mouth breathing and snoring. Mom did chat. I was not doing sleep questionnaires or even asking the questions in person, but we have them on our medical histories back then about mouth breathing, snoring, tonsil and adenoid removal. Wasn't just starting to kind of pay attention to it. And so it was raising my, kind of raising my antennas up a little bit when I was seeing this at this point, even though I didn't fully understand it. And she's bruxing, right? Look at the wear. I'm sure a lot of you saw that right away. You know that those uppers and lowers fit together like a puzzle. Some people look at these, and a lot of times younger docs will look and they'll be like, oh, she chipped that front tooth. Have them go to protrusive and edge to edge. I guarantee you the majority of the time, those upper and lower teeth fit together like a puzzle. If we look at the chapped lips, chapped gums, all these other indicators that are more than just the teeth, right? Just having some social issues and struggling in school as well. So even though we didn't have a cone beam, we still were able to tell quite a bit about this patient. I get that question a lot. Mike, do I need a cone beam? I don't have one. Not everybody can get one. I get that. I hope it gets there, but it's not yet. No, this patient, I wanted to show this case because I didn't have a cone beam on her yet, but I saw all these other clinical indicators and I saw these other signs, and I looked and took a more thorough history, and I started to figure out that that is a different way of approaching it than in this patient where we failed to recognize all those things, right? Similar patient, and it's even the same canine. That's in this patient's erupted labially, but even the same canine that's crowded. So when we talk about how we take a patient-centered plan, we're going to expand the arches and get transverse correction. We're going to do a herps for AP correction. Now, I know some people are they feel that the headgear effect of a herps is retrusive. I have 2 daughters, mid to late teens now. I'm just not a fan of telling a 13, 14-year-old girl that I know I can get them a great occlusion and a great result without surgery, that they need surgery. I'm willing to take a little bit of the headgear effect. I'll take incoming for that. I have the research and the data to back up the orthopedic effects you get if you treat them at the right age with a herps. I've done hundreds of cases with herps and had amazing results. So yes, if you really wanted 100% correction with this girl, would you put her would you do jaw surgery? Yes. But I practiced in a suburb. I was treating real people. I wasn't just in academia or running studies. I had to think of what these patients and parents wanted. And a lot of people just don't want their child to go through that. And I don't blame them. And also, you know what? I would have had to leave her. She's 11 now. I'm not doing surgery at 11. What am I leaving her like this till she's 14, 15? I think we need to think about that. It's really convenient to just say, oh, we shouldn't do anything like a herps or class 2 elastic because they have a retrusive effect on the maxilla. Maybe so, but my contention is any treatment going to be absolutely perfect? We should try to minimize the retraction, maximize the transverse, and provide a reasonable treatment plan for our patients. And then we use braces to level and align. So her plan took a little longer. I probably wouldn't have taken that long later in my career, but it was still, thing that wasn't quite as efficient with things. Really, really nice result overall, right? She was not the best compliant patient. She actually missed some visits. Her family owned a diner locally, and so she would go like months without coming to see me because she was working and going to school. And so that was part of the reason treatment got delayed a little too. And she just was not super great on her hygiene. But the results overall were solid. We look at here. I have ways I use a herps and don't flare the lower incisors. I teach that. It's on my long list, of course, is to build is one that I teach how to do that. But the residents I teach, I explain that to them, but there's ways to do that. We just look in 2D. This was with a 3D. I'm going to show you her post airway and because I have that, but the pre-treatment 2D, you look at the patency of that airway. It's changed dramatically. And we see the nice balance and the fullness of the profile that we're able to achieve. And like I said, that posterior pharyngeal airway, there's no comparison what we're dealing with even in 2D. And anybody who's looked at a couple airways on a 3D knows that's an airway, right? So no, I didn't do jaw surgery, but I will take that airway all day. I mean, that's tremendous. I mean, you almost never see a minimum area of the high twos and a total volume up in the high teens. I mean, that's a tremendous airway. So I will take that all day long. I don't judge these as like, I don't diagnose sleep or issues or breathing issues off of these the airway analysis, and this is ICAT I use, but mostly all the 3Ds do them. I like them more for comparison. I didn't have it in her because she was pre-3D, but I really like to see what I changed, because some patients can have really narrow, you'll be surprised some of the narrowness of some of these patients' airways, and they're like, oh no, they breathe great. And that's why, again, this is multifactorial. That's why it's not a monotherapy fixes everybody, right? Our job, and Jeff Rouse, who's on my show not long ago, we talked about that, is to normalize anatomy. It's all I'm trying to do in these patients. The difference between the patient 1 and 2 and 3 and 4 is, one, we try to normalize anatomy, and the other, we tried to treat their teeth and make them fit together the right way and just give them a better bite, so to speak. Again, because it's patient-centered, I did now have a 3D. So I looked, it's not the worst turbinate hypertrophy, but she does. So I did make a referral to the allergist for them as well. Don't think she ever went, but I did refer. So we look at the before and afters, and really, nice result overall. Again, she had some gingival overgrowth, which sometimes I go in and do a laser with that. Sometimes I let it heal, especially if patients don't want to go through the laser, or money or cost is an issue for that. So we'll kind of see how it heals with the retainers, and you'll see how hers healed. But I did some recontouring of the edges. I love doing that. I love reshaping the teeth. I just, kind of the restorative dentistry background in me. I did restorative dentistry for a few years at my family's practice while I was a resident, and I just really enjoy that aesthetic side of it. So instead of trying to bond incisal edge of a central, which anybody who's done it knows is really hard to get that to stay, I just like to kind of get those teeth looking as best I can with some reshaping. And look at the change in the arch form that we got with her. It's really tremendous, the change in the arch width and the development that we were able to get with her. Look at the lower arch. Now think of the before and afters. I'm going to show you, but just think of the before and afters of the patient that I showed you, patient number 3. Again, this patient now has her second molars in, but look at the change, and look at the canine. There it is. We had tons of room, and you saw we didn't flare her lower incisors out. You can do this because we had to address the transverse. If you just tried to push these teeth apart, yes, we would have laid her incisors out, especially with our Herbst on her. But the technique is so important, but it's because we took the time to diagnose what was actually going on. Got her a really nice occlusion on that class 2, more class 2 side, which the asymmetries, again, I find the Herbst is great for those. And we now want to look at the difference, right? What is the difference between the tooth-centered approach and a patient-centered approach? So on the left was patient 3. There's her upper after treatment. On the right is patient 4. We removed her upper first buys, and this patient we didn't. Where do you think the tongue has a better home? Which patient do you think is going to be a better breather? How about their lower arches? I mean, stop and look at that. Patient on the left is patient number 3. Patient on the right is patient number 4 that we treated with arch development and expansion in a Herbst. I mean, it's not even a question. It's, again, this, we treated the teeth to try to make them fit. This, we treated the patient and used light forces and developed the arches. And this is where they started. These are their starting profiles. This patient was forcing her lips together. You can see the mentalis strain. This patient wasn't. I would contend that if the patient on the right didn't touch her lips, she'd look more like this. And if this on the left, conversely, did touch her lips, she'd kind of look more like that. So not too far off. But if we just look at where patient 3 started and patient 3 ended, let's look at where patient 4 with the patient-centered approach started and where she ended. Now, again, I will take that all day with that Herbst, right? Because this kid got treated. Now she's 13 years old. She's beautiful. She's got an amazing profile. And why would I make this kid wait to do jaw surgery on her when I can do it effectively at this age to get her to look like this? And that's them side by side. So on the left, a tooth-centered approach, and on the right, a patient-centered approach where we looked at more than just the teeth. There's them smiling post-treatment. And the patient on the right came to see me 7 years later because she hadn't been wearing her retainers, and she was now obsessed with how perfect her teeth were and saw a little bit of change on the vertical of those incisal edges. So she wanted to get some new retainers because she didn't want anything to move. So for people to say it's not stable, that canine that we got in, look at the health of the tissue around it. Look at the health and the thick fibrotic tissue around these incisors. The whole myth that we can't expand that intercanine distance and it's not stable. And it's because the treatment wasn't performed properly. if you do it in the right way and you go back to the diagnostics, if you diagnose it correctly and then develop the appropriate treatment plan. I mean, look how her gingiva healed. She's got just an absolutely beautiful, stunning smile. So that is the difference. I hope I was able to draw for you that contrast between a tooth-centered approach to treatment and a whole health patient-centered approach to treatment.
Wow. Okay. Well, first of all, thank you so much for your candor. And really, it's a lot of bravery to show the cases that didn't go well. I know that must not have been easy for you. So thank you for sharing that with us. We can all learn. And there are questions here, but I am really struck by some of the comments that you said, is that this is the way it's being taught. And I have to ask your opinion, Mike, because now you're in academia and now you know the patient-centered approach and the tooth-centered approach. Why do you feel like it's being taught this way?
The first one, the easiest answer is old habits die hard, right? And it comes from the accrediting boards, and we can beat up on the residencies and the directors all we want, but at the end of the day, they have to follow a certain formula or they don't get accreditation. So for those out there who have pull with the ADA or AAO, especially the ADA, who I believe CODA's through the ADA, we need to start to look at the cases where the requirements that we're upholding our residency programs to fulfill, right? We need to start putting requirements in to get these kids in treatment earlier. Now, that takes me to the second point, which I alluded to and you and I spoke on the podcast, and that's the system's broken. So the medical system, right? The healthcare system. The first was just the kind of the orthodontic educational system. The healthcare system's broken. And that's because, we say, well, we're not getting these patients young in a residency. Well, in the majority of orthodontic residencies, there's a pedo residency like down the hall, right? They're seeing young kids. They're seeing these malocclusions young. If they're not, we could certainly teach them to detect them at a younger age. But the orthodontist, I hate to say it, a lot of times their hands are tied. They just can't do anything about it young because of, it's called the Saltzman Index, which was developed in 1967, 8, call me one of those 2 years. And that's what we're using today, 50 years later, to judge how, if it more than that, going on 60 years later, to judge how we determine if a patient will get state funding for their orthodontic treatment. And they don't count the primary teeth and they don't count crowding if the primary teeth are there. So that patient 1 that I showed and patient 2, actually all of them. I mean, even the overjet being severe in the third and fourth patients, you're not going to get enough points. I think you need 26 points. You're not going to score high enough. So those patients, the orthodontic residents are forced to wait to treat these patients until they're teenagers. It's the system. So we've got to change the system. We can show it all we want, but we've got to change the system.
Wasteful watching, that's kind of true. Also,
not the truth. Yeah,
watch and waste time. So we do have some questions. One's a very straightforward one. What is the minimum age for CBCTs?
I would not be the one to answer the minimum age. I look at, I didn't see many patients under the age of 6 in practice. I think you guys like Kevin Boyd would be better, more well suited for that, for the actual data. I know I don't want to speak for Kev, but he takes them real young. And my contention is, actually at our meeting a couple of weeks ago, he was talking about that, what is the big deal to take these on 2, 3, 4-year-olds? I mean, now that we have low dose protocols, the radiation, I mean, you could get these things for 10, 12 microsieverts on these little kids. Background radiation, it's like 2 days of background radiation. It's nothing that is, I see Kevin hopping on there. I'm
going to see if he wants to. I know he's here, but
let's let him chime in on it. But we're not talking about significant doses of radiation. We'll take, and it's, to me, it's, a LAR principle, right? But what do we have to gain versus what do we have to lose? So no, we don't want to go over radiating these patients for no reason. But if we see clinically that there's other issues, breathing issues, airway issues, for sure, like in most of the kids walking into an orthodontic office at 5, 6, 7 years old at the youngest, I have no hesitation to take a low dose. They'll take a pan, right? Standard of care is like pan starts at 6 years old-ish, maybe. I don't know if that's changed. The pediatric dentist would know better than me. But I mean, we'll take a pan at 6 and not even think twice of it. Well, a 2D pan that regulation was put out before digital, when you were taking film-based pans, which are like twice the radiation of digital, which would be like 4 times the radiation of a low-dose cone beam. So we were fine with taking a pan of say 40, 35 microsieverts on, or 40 microsieverts on a 6-year-old. But now we're going to argue we shouldn't be taking a cone beam with 10 to 15 microsieverts, depending on the field of view and the low dose.
I don't think Dr. Boyd's able to.
Yeah,
Okay,
I,
that's fine.
Oh, yay. Hi, Dr. Boyd. How are you?
Hey, Kat.
anybody. Hi, thanks. Mike, I am just so appreciative of you showing us not your best stuff. And I kind of call it generous courage by you.
Thanks.
It really was great. In
Thank
terms of the radiation, yes, you reiterated, and this was presented at ADA, like the 8th annual pediatric.
Sorry, Dr. Boyd, you're kind of in
Airway
and
conference.
out. Maybe you
And
could put
7 microsieverts.
But we're losing you, Kev.
Yeah, we're losing you. Maybe you can put the answer in the chat and then I can read it
Oh,
out because
yeah.
you're glitchy.
Can
And then,
hear me
and then
now?
we'll
Can you-
circle back.
Can't
We'll
hear
try
me.
one more time and then we'll see.
Yeah. The background radiation of 2 days of being outdoors, that's about 7 or 8 microsieverts. And
Mhm.
that in the literature is from Ludlow. And this was presented at the ADA. And my, presentation was vetted by the scientific committee at the ADA. This is not safe. I'm not cavalier about ionizing radiation, but
Mhm.
we need to be getting low dose cone beams or at least a SEP and pan on children before they turn 6 years old. Every kid should have this.
Mhm.
If there's crowding, that is an indication to do the x-rays.
Yep.
So thank you for presenting that very accurate.
You're welcome. Thanks for the input as well.
Thank you. Thank you. Another question for SLP, myofunctional therapist here. Are you getting skeletal expansion without expanders? Am I understanding this correctly?
Yes, that was what I was talking about with the studies going back to Ricketts in the 70s. And it's just, if you do research on slow maxillary expansion versus rapid maxillary expansion, it's all age-based. So the earlier, the better. You will see more skeletal change with light forces. You don't need rapid forces. You don't need turnkey expanders. Ricketts developed the W arch and the lingual holding arch in the 70s. And he used blue alloy, which was a type of stainless steel. And he was able to get it down to about 400 grams of force that was able to get skeletal change. And there's tons of evidence in the literature about this. Now, that evidence tends to go away the past like 20, 30 years because no one's doing research on this. I am actually working on some projects with the residents at Nova to try to get some of the data that I have to analyze to quantify that. That being said, I could show you cone beam after cone beam after cone beam. You saw the one in this patient. I mean, clearly her maxilla changed. It was not tipping teeth. So there's 3 types of expansion. There's dental tipping, right? There's dental alveolar expansion, which is where the tooth generates new alveolar bone as you do slow expansion. That's why sometimes you can get really nice expansion in transverse development in even adults, right? You're not splitting their suture unless you do a MARPE or a SARPE or a dome. I mean, you're not getting skeletal change in that sense. But you see this arch development and expansion. I could show you tons of cases with that. That's dental alveolar. And then there's sutural orthopedic expansion. So when you say you're getting orthopedic expansion, I'm assuming you mean the sutural type. But yes, just because you don't, it's a big, big, big misconception. You don't need to see a diastema to know you're getting skeletal orthopedic change. Remember Melson's article from 75. Look it up. She goes into detail on the histology of this. The suture is not tortuous. When you start getting 10 to 14 in that adolescent, the juvenile, remember it's infantile, juvenile, and then adolescent, it starts to be more challenging. So you just go to try to do light forces on a 12-year-old, 13-year-old, you're going to get less sutural change. You'll still can get great dental alveolar change, right? You saw that in that last patient I showed on her lower arch. Look at how much amazing dental alveolar change we got. It wasn't skeletal. I didn't split her mandible. And the mandibular symphysis is fused around birth. So that was all dental alveolar, right? But on the upper, when you have the deficient maxilla, you do get some dental tipping always when you expand. You're going to get some dental alveolar expansion and you're going to get sutural change.
Wonderful. What do you feel about the tongue ties? There was a specific question on the 3rd case, but I think that's when you're being tooth focused. And did you even address the tongue tie back then when you were in your tooth focused approach?
No idea. No idea. And I was late to that. on my cleft craniofacial team, we started looking at that a little bit more, and I would refer for them, but I was pretty conservative on it. I've learned more about that since I've been on this journey the past couple of years, speaking with the myofunctional therapy groups and individuals, and getting more of a sense of what that all involves. The Dean Drews, who were, we saw a couple weeks ago, and just getting a sense of what's possible. But again, we're not learning this. So I'm not ashamed to say that a lot of this just wasn't even on my radar. If I saw a real persistent tongue tie, absolutely. But I'm sure there were multiple cases that I could look back on and realize that I could have been more aggressive on releases for the lingual freedom.
And then what about oral facial myofunctional exercises, especially in those class 2 patients? Were you incorporating that at all when you're practicing?
Nope. I had no idea about myofunctional
Okay,
thank while I was in practice.
Gotcha.
And we didn't even have one in the area. Now, ironically, in upstate New York, there is one, I don't know if she's on this call, but who has reached out to me because she now can't find an orthodontist. So all this time, I didn't have anybody to work with in the myofunctional therapy side now. And maybe she was there. We didn't know of one another, but it wasn't something that was common. And now she can't find an orthodontist in that upstate New York area that has any airway awareness or ability to look at it for more than the teeth. So she's struggling when she sees kiddos to even find an ENT or an ortho to work with. So it is a problem.
How do you feel about clear aligners helping with these treatments of changing the shape of these arches? Granted, it has to be for kids or teens that are responsible enough to use them.
Yeah, force is force. There's certain other drawbacks of plastic. I use a lot of Invisalign in my practice. I use a lot with the residents. As long as you know what you're doing with plastic, it doesn't have to be Invisalign. It can be any clear aligner product that you like. It's all kind of for many years when I was practicing, Invisalign was the leader. There just wasn't a lot of other good quality competitors, but now there's a lot of other good companies out there that do what Invisalign does, if not even better. So yeah, I did some crazy complicated stuff. Compliance is always the concern. Invisalign First, I think, has people ask about Invisalign First for the patients like the younger patient 2 that I showed. I didn't love it in the little bit I dabbled in it, because I found that patient I told you, it was like 4 visits and 1 progress appointment to bond the laterals. It was quick. It's easy. It's as mom said it and forget it. Invisalign, when those laterals come in, you got to adjust the trays and you got to account for that and have them kind of blocked out. And if they don't come in where you think, then you got to rescan and hold them, everything in between. It's not that you can't. I've seen tremendous arch development and expansion, not talking about the IP, Invisalign palate expander, just with Invisalign First, because it's delivering the same type of force as the NiTi wire. You're getting tremendous transverse expansion with plastic, just like you can with wires. And it is orthopedic, as well as it's not just dental tipping and not just dental alveolar. But I just found it cumbersome in my hands. Where I do think it has a place, and I've never done this, would be in the younger kiddos who are in the primary dentition, who you could go in, and those kids, I know number of people who are starting to do it in that age group and having some really great success. And instead of putting bigger, bulkier expanders in and having the compliance, just using Invisalign First for that, or whatever. I don't know. I don't even know if other clear aligner companies have a system for the younger kiddos like that. But yeah, so it's not that you couldn't do it. I know people who are doing what I do with braces in phase 1 with aligners. But for me, it was just a lot more work to just get everything, the incisors lined up just right. I mean, it was just so easy and efficient with the brackets and wires. And the kids loved it. The kids love their braces at that age. They literally love their braces at that age. It's like they are excited and they know it's making them feel better and look better. And they know it. I mean, they might not be able to express it, but they know it.
I love that there's all different techniques. I mean, we just had that Airway Health United Leadership Summit, and we saw a lot of different techniques. And it's just so interesting to see how people use the tools differently. But the same goal is for better patient health and better airway health. So I love seeing your techniques tonight. In fact, Dr. Brett Christensen, who's now your new colleague and friend, he said, awesome to see your progression. He's with us tonight. And he has a question. What about the nasal changes with just dental alveolar remodeling?
Well, I'm not getting just dental alveolar remodeling, but, and that's part of the study we're doing. We're working on at Nova, is try to quantify the exact changes. I make some linear measurements that show it. But again, you are getting orthopedic change. Remember, you don't need heavy force to expand the suture of a young kid. You just don't. And I can give you plenty of studies on that. Ladner and Mule had a great study on that. I mean, there's a lot of evidence out there. Bell had a lot of studies in the early 80s that you can use light forces. And like I said, Ricketts was a leader in that, and you just don't just don't need Tom Pitts. Tom Pitts told me he hasn't used an RPE on a younger kid since the 70s because he was a big disciple of, he knew Ricketts. So he was working side by side with him, and Tom is a legend. And it's a great episode if people want to hear, to listen to that episode on my show, because Tom we talk a little bit about that. But yeah, I think that's a big misconception in the orthodontic arena, is that we need heavy RPE type force to get orthopedic change. And you don't. And then the other part of that, Brett, is, remember, when you get improved tongue position and they start being able to breathe through their nose better, it is a use it or lose it phenomenon. And they are going to get more nasal volume and capacity and expansion just by being better nose breathers and using their nose. And I saw that all the time.
Well, I think I just asked if you wanted to come on as a panelist or join the Q&A. So I don't know. Again, no pressure, Dr. Christensen, but
Can you hear me?
there we go. Yeah, we can hear you.
Hey, Brett.
Thank you.
Hey there. Hey, it was good seeing you out there in Florida. And I just got done with patients about a half an hour ago, and so I've been in the last part of it. But what I saw was amazing. I love to see your progression. You know, it's really cool to see how we are changing the way that we're even thinking. And it takes somebody that's humble like you to look at that and say, hey, look what I used to do. And I say that every day. And I'm not doing it the way that I did. And you know, I would love to be part of your study, because I've got tons of patients before and after VCTs with you know, regular expanders. I'd love to throw those into your study, and let's compare notes, because I am all for whatever is the best way to treat patients. And I have said time and time again, if I'm not doing something the best way, I will change and go a different route. And the way that you're looking at things is exactly the way that we, as a whole profession in the airway industry, needs to look. We need to have data. We need to have proof. And the fact that you're doing that is right down the alleyway of what everybody needs to be looking at, instead of, you know, conjecture. And I think this is what happens. So
thank you. Appreciate that.
Thank you, Dr. Christensen.
Thanks.
Do you believe all extractions can be prevented if treatment is initiated early enough, or are there some patient cases that may still require extractions?
I'm always hesitant to give an all or never answer to anything. I try not to be dogmatic or extremist on things. I feel like there's always an exception to any rule. That being said, I am willing to say, you know, the vast majority, if not 95% of cases that I was able to get at young, I did not have to extract teeth. Actually, more than that, probably 99%, truthfully. I mean, I'm struggling to think of one that I did, but I hesitate to say all. But when you get them young, and young by my standard, I know Kev refers to a lot of those patients as geriatric, that for the orthodontists are young in the perspective. But we as orthodontists, it's a struggle and a fight with my orthodontic colleagues just to get them to want to do any of this on 6 to 8 year olds. Going to 3 to 5 year olds is a whole nother animal to try to tackle. So for us, 6 to 8 is young. And when I got a patient at that age and was able to do my arch development, I mean, it's just almost unheard of. You'd ever have to extract a tooth, except for an extenuating circumstance.
Thank you. How did you use Herbst's forces without dumping lower incisors? That was not my question.
Yeah, I was like, wow, that's impressive. Yeah, really. But no, that's a much longer conversation that I can probably give justice to right now, but I'll just give the end of it is, the key is that you don't put the brackets on the mandibular incisors in the beginning. It's counterintuitive. John Budaris and I actually disagree on this. He's one of the pioneers in Herbst therapy, but I'm big, and that is, you know, a lot of people think you need to put the brackets on those lower incisors and lasso them back. And trust me, it's a bit humbling with a case like that when you've got an impacted canine and you're not bracketing them, because I wanted my orthopedic change first. But that's the most effective way to do it, is to deal with your AP before you get on them. And it has to do with the orthopedic force versus the orthodontic force, and stimulating the osteoclastic coupling in the PDL. So, but there's biologic reasons for it. But that has been a big trick. I didn't always do that. So early in my career, I did see a lot more flaring. But once I got that tip, it was a complete game changer. And yeah, you saw, I mean, tremendous class 2 correction, tremendous development of that mandibular arch with virtually no proclination of those incisors.
Is there treatment for adults that you do?
I'm not sure I know.
I guess maybe, would you use the bracket and wires on adult dentition as well?
Would I use the brackets and wires on adult dentition? Like, oh, for like expansion purposes? Yeah, absolutely. There's certainly a lot that you can do. I did a lot non-surgically on adult patients who, not every patient, but there's a lot of things you can do. And with Invisalign, we're keep saying Invisalign because that's what I tend to use most. But now there's a lot of competitors that are great, as I said. And you with clear aligners. I mean, you can use clear aligners. You can use brackets and wires, and you can get tremendous development of the arches in adults, slow, light forces. Now, that is dental tipping or dental alveolar. You're not getting sutural skeletal change. But if you want to make, again, we know that this airway thing is multifactorial. We know there's no monotherapy. Well, if you're increasing the tongue space and helping with that side of things, that only is going to help overall from an airway perspective. But again, you have to look at each patient. That gets down to the diagnosis, right? If you have a patient who doesn't have a significant airway compromise, they're transverse, they've got some pretty broad maxillary bone transverse, but they're really caved in arches. They have some scalloping on the tongue. Maybe they're having some mouth breathing or snoring. It's certainly not wrong first before you put them through something more invasive. Just go do some expansion on that arch, upright those teeth, develop that arch. I've got tons and tons of cases I did that on adults for. Works beautifully. And then sometimes you do that and they still have a problem. And then you've got to get more aggressive and try to take it to the next step.
Do you feel a CBCT image is required for proper diagnosis for these issues?
No, not required, but it is not possible to do the same type of diagnosis without it. So in other words, like I showed you in that one patient 4, I was able to figure out what was going on overall without having a cone beam. So in other words, it's not like if you don't have a cone beam, you can't be airway aware or understand what's going on with their growth and development, because I gave you all those other indicators that you can use to try to recognize when these patients have a breathing problem. That being said, as you clearly saw in that first patient, you're not seeing those adenoids in 2D, and you're not seeing those nasal passageways in 2D. So you are limited in your ability to refer to your medical colleagues accurately, which I refer to the allergist, the ENT all the time, if you don't see it in 3D.
Great presentation. They said, what would be your patient-centered approach on a 5.5-year-old that has the clinical signs, small arches, multiple yes answers on the PSQ? Would having an ENT evaluation be a good start prior to ortho evaluation? I know you just had that call, your podcast with Dr. Dave.
Yeah. Again, if you have a cone beam and you can see what's happening otolaryngologically, and you can see the nasopharynx, the oropharynx, and you can see in the nasal passageways, look at the turbinates, the septum. If you can sense there's an issue of obstruction there with a cone beam, then absolutely. I mean, on any patient you detect that in, I look at it as our job is to detect that and then refer it, right? I'm not the one that's going to tell them you need your adenoids out, or, you need a nasal steroid. I know some people are more comfortable with that. I try to stay in my lane as much as I push the envelope on things, but whereas, a saline or an Xclear or nasal hygiene, that's different. But when you start going with more, first trying to recommend, even if it's an over-the-counter medication of that sort in an area that's not necessarily our wheelhouse, it's my training to recognize the issue and then get them to the appropriate person. Because am I just treating the symptom at that point? Like, I'm critical for just treating the teeth. But if I'm telling them take a nasal spray, what's causing that nasal passageway to be obstructed, right? So I don't want to be hypocritical and overstep, just acting like I can solve everything. I want to get to the cause of everything. And I want them to get to the appropriate professional who can figure out why they're having that problem. Now, that person, as part of that, might put them on a steroid nasal spray, fine. But I like to try to get them. So I never would say don't send the patient to the ENT if you detect those things. If you have a patient who, it's just so tough to answer it in specifics because every patient is so different. When you see a patient who has certain telltale signs, you can tell the ones that typically the ENTs are going to have some work on. But without seeing the images, without seeing the patient clinically, it would be I wouldn't want to mislead you on that. I would just leave it at, it's certainly warranted to send the patient who you think has some sort of airway obstruction in the nasal passageways and or pharyngeal airway to an ENT. But finding one, that's something that Dave and I talk about in the episode coming out this week too. I mean, it's not always easy to find one. And that's something I hear a lot about from people that I coach and help. They're like, I can't find an ENT in my area. Are the ones that do treat these young kids are booked out for 9 months, a year. And so that's another problem. And I talk about that in this week's episode with Dave and some of the things. He's in Australia, so the healthcare system's a little different, but I think that's another big challenge is we have to educate the ENTs. The ENTs need more education on this as well, so that when we do send them these patients, that myofunctional therapist I referenced where I used to practice in upstate New York, she, as I said, she's so frustrated. She can't find an ENT. She sends these kids to the ENT. The ENT is like, nope, can't do anything.
There's
What
a
do you
question of how early of an age that you start treatment.
I think we covered that, but it's typically for me, it was that 5, 6 age range, just because that's the earliest I was getting patients. Yeah, I just didn't see patients just didn't walk in my office younger than that, really.
Right.
Happened.
Some of these you covered. Okay. Are there any resources that you can suggest that they can share with local orthodontists that are not as airway focused? And do you train on your techniques? So I want you to give your follow-up information on how everyone can reach you and learn more about your coaching and your courses as well.
Sure. I can show some of that now if you want me to.
Sure,
I can just
absolutely.
I think I had it at the end here. So let me just go to it. So I do train on this. DeLuke Orthodontic Coaching is my platform, theorthocoach.com. I built this platform in the past year and a half, still in the process of building it. I do have courses that go into my archwire approach. I have courses that deal with cleft craniofacial. I'm still working on multiple courses to launch. There's a couple free courses on there too. I have the podcast, which has a ton of info. If you scan this QR code, it'll take you to all these avenues, from Apple, Spotify, Facebook. If you want to join the doc community, I'm building that, in the process of building that on Facebook. Just request membership and we can have you as part of that. A lot of the Facebook groups tend to be specialty or focus on one group, like they're just mainly orthodontists. And so I'm working to create something that's multidisciplinary, that has all the types of people that are on this call in it, so we can all start to share ideas. And again, it's in progress. It's in the earlier stages, but I'm going to start trying to ramp up some of the content there. I have a YouTube channel with a lot of content. If you go way back, so before my podcast started taking off, I was just kind of building some courses on YouTube and putting them out there. So if you go way back, and I can even send some links to Lauren if we want to send those out, on a more thorough evaluation of how I do my phase 1s of cone beam and what I look at in cone beam, that's all free on YouTube. And then Instagram page is a work in process. I told Lauren, I don't love social media, just personally.
Right.
It's a struggle for me. I'm in that next generation that, it was after us that it came out. We grew up not without it, and I just don't love it. So that part's a struggle, but I know it's necessary to get the message out.
I think remember the dial-up internet, right? Those noises.
Exactly.
Right.
Exactly. So yeah, it's just that side of it is not my forte. The coaching with me, I do private coaching personally for people. I don't just coach orthodontists. I coach general dentists, pediatric dentists, and orthodontists. My course is available. I'm ADA CERP recognized. So my big course that goes into this in great detail, like A to Z, there's some people on this call who have taken it. That one's like 26 3/4 hours. And I have ADA CERP certification. So you get 26 3/4 hours of ADA CERP recognized CE for that one. That's a big course that I built that literally goes through everything I do, down to like what brackets to use, what prescription, technique, visits. I mean, it's really comprehensive. So if you're looking at getting into it at that extent, you could, but you can always just set up a coaching call with me if you want to go through some cases or have some ideas. I have a lot of people who do that as well.
Wonderful. Well, thank you so much. You're a tremendous resource. I'm going to go ahead and share my screen for a minute too. There was something we spoke about on the podcast that I just wanted to bring up because it is Dental Hygiene Month, and it also is Orthodontal Health Month. And we were talking about the AAO's recommendations of treating, they say up to 7, but maybe if you could stop sharing your screen for a moment, then I can just kind of bring up.
Be good.
I just wanted to share this. I think it's really important. If I can go to my screen, here we go. You can see that full screen, right?
Yeah, I see all the slides. Yeah.
Yeah, I just wanted to see kind of your opinion on this. With the AAO, if you're just a mom and you Google when should I bring my child to see the orthodontist, I thought it was
It's actually,
really
I'm sorry, Lauren, it's
interesting.
the small version of it.
Oh,
You
it's
might
a
be
small version. Okay,
from
hold on.
current slide on the upper left
Thank
there.
you.
Yep.
Let me. Oh. See, it's this generation. Okay. That make you feel better.
There
Okay.
you go. We're good.
Anyway, here we
Yep.
go. I just thought it was really interesting, and I think the timing is right. That it's Orthodontic Health Month. That if you're just a mom and not just a mom, if you're a mom and you're looking for advice on when to take your child to see the orthodontist or orthodontic checkup, I found it very interesting that it says if your child is younger than 7 and you notice something that appears, quote, off, you don't need to wait until your child turns 7 to see the orthodontist. Regardless of age, you should take your child to an orthodontist the moment you notice an issue. And then some of these issues here that they listed are very interesting. And it's mouth breathing is one of them. And I don't think many people are aware of that, so I don't know if this is relatively new that they added this to the recommendations. They also talk about facial imbalance, which will recognize soft tissue dysfunction. So maybe we can just, what are your feelings on this? And then if they do bring them to the orthodontist, is the orthodontist prepared?
Well, it's a very good question. So first on are people aware? So I, in the orthodontic study groups, and I posted my episode with you, I told you this separately, that there was some interesting blowback. I get a lot of heat from my orthodontic colleagues for speaking the way I do. And I'm not intimidated by that. I have the experience to back it up and the research and the data to back it up. And so I try to call balls and strikes on this and just be fair, because my goal is to help kids. My goal is to advance our profession and help all kids who are struggling. The kids that you saw, patients 1 and 3 that I missed it in, I don't want that to keep happening. So they brought up some points about some of the things we talked about, and they didn't like our comparison of obstructive sleep apnea to end of like stage 4 cancer. And anyway, so there was a lot of things that were going on. There's a lot of airway haters out there, and they look for any chance to jump on things. So it's kind of going back and forth. And then one of them, I referenced the AAO, and they brought up about the AAO, how you said that. And they said, people love to say that it's misleading. The AAO really doesn't want anyone treated by 7. That's what their stance is. And I posted back about it because this is their stance. And I'm so glad you brought it up. They don't say kids have to wait until 7. I don't know where that comes from, but I have never seen it. This screen you show, I looked probably a year ago, and this was what it was. Maybe not the exact verbiage, but it was something close to this. I vividly remember the signs your child may need care. That specifically, I remember the first paragraph of the blue box. The bottom one, I can't remember if that was what it was or not. But the point is the AAO is not telling you that you can't treat a patient before 7. So when people in the orthodontic profession get out there and try to intimidate you and say it is malpractice, there's going to be lawyers coming for you, all things that I've heard people say publicly, that if you start treating these kids younger, there's no standard of care. It's a breach in the standard of care. It's not correct. You as long as I like the ADA's standpoint, and that is from their position statement in 2017. And that is our job, all dentists, any specialist or general dentist or even hygienist, we're supposed to recognize initially the problem, right? And then the dental practitioner is supposed to make the appropriate referral to our medical colleagues for their area of expertise, and then provide evidence-based treatment for our area of expertise. Well, last time I checked, expanding a patient who's maxillary deficient and has a narrow mandibular arch is evidence-based. And last time I checked, there's no age at which you're allowed to do this. And to say otherwise is really not in line with the literature and the facts, but it is a scare tactic people use because they try to intimidate people from doing this earlier. So
well, here it is in black and white, right? So you can go to the website, share that with maybe with your colleagues and your patients. And then also the other tool that I love is the brochure from the ADA. And it's actually saying similar things like what signs should parents watch for? And the most obvious sign that a parent should watch for is mouth breathing. right? So they're really on the same level. It's just about, connecting the dots. And that's why I'm so glad everyone's on this call today, because we do have the tools. We are making headway. We are a movement. There are many like-minded people. If you actually wanted to join our Facebook group too, this is free. It's for professionals. You can join our Airway Health Meetup Facebook group, where we post things like this and these ideas to help everyone move along. And then also the Children's Airway First Foundation has wonderful resources too. I told Rebecca, the director, that she has to get you on that podcast as well.
Awesome.
So she'll
Thank
be
you.
reaching out to you. I don't want to take too much time with our offerings. I think most people are aware of Airway Health Solutions and our courses. I'm going to invite you to look at our website. We have new courses and really exciting electives for everyone to take with a little bit more flexibility. I do quickly want to mention that we do have our Airway Palooza actually at the Westin, and that is going to be October 17th and 18th. So basically a year from now, and we're announcing our speaker lineup fairly soon. So stay tuned for that. And I think it's a wrap from there. So I'm going to stop sharing, and I would love to give you any type of final thoughts, Dr. DeLuke, or any words of encouragement for those orthodontists who are out there who are airway curious and perhaps bridging that gap together in the community. You're doing such a great job. So thank you.
You're welcome. And thank you for having me and giving me the opportunity to talk about it. I would encourage, it's kind of two parts. I would encourage my orthodontic colleagues, just keep an open mind, right? I wasn't trained to do this. I didn't learn to do this. And as I said before, it can be very humbling to look back at your body of work. I was fortunate that I only had on a very early part of my career, residency, when I just started practice from those cases. And I quickly realized it was not the way I wanted to treat. So it wasn't as hard for me to make that leap. And I get that if you've done this for like 15, 20 years, it can really be hard to look at it and say you could have done differently. So I ask the general dental and pediatric colleagues, show a little grace. They can be very aggressive and hard on the orthodontists. And I don't think that is really productive. I train a lot of residents. I teach a lot of residents. Not just the residents at Nova, but around the country. I coach and teach and help a lot of them. And they all, when they see this, they get it. They get it. They understand it. They want to do better. They are empathetic. We go into this to help. So let's not divide and make it about the orthodontists don't know what they're doing. Are there some orthodontists you're never going to change? Yes. Trust me. I do battle with many of them online, and it gets pretty vicious. Is there something in the background there? Sorry,
I think you're good. You're good.
I do battle a lot of them on this topic. So I'm not going to say that every orthodontist is you're going to catch a lot. I take a lot of arrows for it. But that's just the loud minority. The majority of people I have reach out to me. I don't have a week that goes by that multiple people don't reach out to me of orthodontists. Like, thank you for fighting for us. Thank you for doing this. I'm doing this. And I'm trying to get more on my podcast. Kristen Connett was on a couple months ago, and fellow UConn grad, and she went on a similar journey. So they're out there. You just need to work together to help the orthodontists see this differently. And the ones I've trained and coached, they get it, and they've changed, and they're doing this. As far as the general dental and pediatric segment, just keep pushing responsibly to your orthodontic colleagues. And if they don't accept it, then you know what? Then you learn how to do it. And that's, I have the content out there. If there's a bunch of people I've trained that have said to me, Mike, I've tried to get the orthodontist to see it differently, and they won't. And okay, then that's part of the reason I putting the resources out there to help you learn how to do it, because my priority is teaching the kids. And I get a lot of blowback from my orthodontic colleagues for even talking or teaching pediatric dental and general dentists about this. And my answer to them always is like, if they're helping kids and you're not, then I don't even know what you're talking about. Like it doesn't bother me. Because I'm about teaching people to help kids in the way I showed you in this presentation. They can be helped, and I'll teach whomever wants to learn that. So summarize: show grace to the orthodontists that aren't digging in and set in stone. Some of them may come around. Let's not be divisive and divide us as a profession. Rising tide lifts all ships. Let's do this together. Let's work together. That being said, I get there are a lot of orthodontists who will never change, who are never going to do this differently. And if that's the case, take it upon yourself to take the steps you need to treat your patients the way they should be treated.
Well said. Let's all work together. And thanks everyone for joining us tonight and your commitment to oral health and orthodontic health. We really appreciate you. And stay tuned for us to announce our next free conversation series in November. It'd probably be a town hall because we have a lot of kind of extra questions that we never got to answer from other episodes. So thanks everyone. Thanks again, Dr. DeLuke. You're a shining light. We appreciate you. Have a good night, everybody.
Thanks so much, Lauren. Appreciate the opportunity. Take care, everyone.
Bye.